Today we're going to be in Chapter 21 talking about the respiratory system and respiratory care modalities, specifically being mechanically intubated or ventilated, and a little bit of review about tracheostomy and oxygen therapy. So our objectives for the day are to talk about nursing care of patients who are intubated, patient education points, as well as home care, important home care teaching points. We're going to look at the nursing process in terms of how to take care of a patient who is ventilated. We're going to talk about weaning from the ventilator. We're also going to talk about chest tubes and hopefully try to help you understand what a chest tube is and how it functions. And then we're going to talk about nursing care of patients related to thoracic surgery. Important patient education as well as home care points. So as usual, in the beginning we're going to do a little review. Oxygen therapy, you had this in fundamentals. You should have had it all the way through, actually, up to this point. So just a basic review about oxygen. Room air is approximately 20% O2. So if your patient's on oxygen, they're only getting about 20%. If they're on room air, they're only getting about 20% oxygen. So our goal for oxygen therapy is to get enough to transport or provide enough oxygen in the blood, whatever the level that is, to decrease the work of breathing and ultimately decrease stress on the heart. Because remember, it's supply and demand. The more the heart needs, which would be greater the demand, then we have to up the supply. So oxygen transport, of course, depends on cardiac output, arterial concentrations, hemoglobin levels, the body's demand. A lot of different things play into that. Two important terms: hypoxemia, low oxygen in the arterial supply. Okay? Hypoxemia means low oxygen in the blood. There may not be any physical symptoms that you see, but their oxygen level in the arterial blood supply is low. Hypoxia means that we have decreased oxygen to the tissues, to the periphery, outside of just the bloodstream. Hypoxia is where you're going to begin to see the symptoms. Increased cap refill, pallor, circumaural cyanosis is a very late sign. So go back and review what those signs of hypoxia are, be familiar with them, and then brush up on what's normal O2 level, normal arterial blood level for oxygen off of ABG. So different types of oxygen therapies that we can use to supply oxygen to our patient. We have the non-invasive methods, and then we're going to talk about invasive ones in a little bit when we talk about intubation. But our non-invasive methods of oxygen delivery are, of course, nasal cannula, a simple mask. A Venturi mask is where you can actually adjust the percentage. You can go anywhere from about 35 up to about 50%. I don't think you can go any higher than 50, but I'm not positive about that. But simple mask cannot be adjusted. Venturi mask can be adjusted as far as how much oxygen is delivered. With a nasal cannula, of course, you can give all the way up to about 5 or 6 liters. Anything really above 3 or 4 needs to be humidified. It's basically, you're going to be blowing your patient's nose and burning them. It's not comfortable to be on high flow nasal cannula. There are some newer types of cannulas out there now. It's actually a combination. It's called Comfort Flow, and you might see it in clinical. It's high flow nasal cannula, but it's actually a modified. It's not just a regular nasal cannula that connects directly to the wall. It's got a humidifier and some other different things on it, which I'm not very familiar with, but it sort of adapts that cannula to where it can run at a high flow. So you might see patients on step down or in ICU even that are on what's called comfort flow nasal cannula, and those might be 15 liters, 20 liters, 30 liters, depending on how severe their respiratory issues are. You might see someone on a nasal cannula on high flow. So if it's called comfort flow, just know that's what that is, and that's okay. You know, advantages to a nasal cannula, obviously it's more comfortable, and a lot of times those cords, they'll give them like a 10-foot nasal cannula cord, and so they can get up and move around the room, whereas with a mask, you know, it's more constricting. A lot of patients that need high-flow O2 therapy are claustrophobic. A lot of them are COPD or emphysema patients, and they are somewhat claustrophobic with a mask on. So this newly developed type of cannula, high-flow cannula, is really beneficial for them. After simple mask or Venturi mask, and then we go to a non-rebreather, which just has a reservoir on it where it sort of recollects that oxygen and allows the patient to rebreathe some of their CO2 and some of that oxygen. Then we move to a face tent, which is just a bigger type mask. It doesn't fit tight against the face, but it can be run at higher flow. It is not the same as the comfort flow, but it is designed, non-rebreather and face tent are designed to be for oxygen delivery at high flow, like 15 liters. A non-rebreather, you might hear them say 100% non-rebreather. If you set a non-rebreather mask at 15 liters flow from an oxygen flow meter, then they're getting pretty close to 100% oxygen. Same with a face tent. If you put a face tent on your patient and you turn it up to 15 liters, they're getting about 98% oxygen. So these are high flow type masks. T-piece trach collar, we can hook oxygen via T-piece or trach collar directly to an ET tube or to a tracheostomy, and the amount of oxygen, the percentage of oxygen, can be dialed in from a very low percentage all the way up to 100%. CPAP and BiPAP, hopefully y'all are familiar with both of these. I believe that we get into some discussion about them a little bit later on, maybe in the next chapter. I don't remember, but you might want to go back and brush up on CPAP and BiPAP if you're not familiar with them. Upper airway obstruction. Some causes of obstruction, which airway obstruction would be a reason why we would need artificial or oxygen supplementation. Basic causes, of course, any kind of obstruction, if you know, food, blood, swelling, vomit, inflammation, dysphoria, sleep apnea is a very common cause of airway obstruction. Upper airway meaning everything above the upper structures, the larynx, the glottis, and then the upper parts of the head. Tonsils, thick, heavy secretions, copious secretions, obviously can block the upper airway. And then another cause that people don't often think about is altered level of consciousness. Whenever the patient is overly sedated, they lose their protective reflex. What is the main protective reflex to keep the upper airway open? It's that drive to breathe, that CO2, low CO2 is our drive to breathe, and it's the cough reflex. Whenever our CO2 levels increase, typically in a healthy person, it is stimulus for the person to take a deep breath and blow off the CO2. Also, whenever there is something in our airway, we have that cough reflex that encourages us to clear the airway. Well, if the patient has an altered level of consciousness, meaning they're overly sedated, then they're going to lose those protective reflexes, and as CO2 increases in the bloodstream, the patient will become more and more somnolent and unresponsive. So, and then the more unresponsive they are, they won't cough. So that's a big issue in upper airway obstruction. So when we're assessing our patient for upper airway obstruction, of course, inspection, auscultation, palpation, these are all things we're going to be doing. Looking at the level of consciousness first and foremost. You can often determine the patient's level of consciousness just by looking at them. Of course, you will try to arouse them if they look unresponsive, but if you walk in the room and your patient is watching TV and interactive, then you know that they're alert. Please don't confuse being alert with being oriented. You must always verify that they are oriented properly, but in this case we're looking for somebody who is awake and alert and maintaining their own airway. What is the inspiratory effort? Are they breathing okay? What is the work of breathing? I'm going to talk about work of breathing a lot this semester, especially in clinical. When we get into some of these patients who have COPD or emphysema, chronic lung problems, we really are going to be looking at their effort and their work of breathing a lot, okay? And what that means is, are they breathing on their own? Are they making good spontaneous effort? Do you have good chest rise? Are they able to inhale and exhale normally? Are they struggling? Do they look like they're working super hard to get air in and out? Do you see retractions? Remember, retractions are not normal in an adult. They're not normal in a kid either, but you're more likely to see them in a child than you are an adult. So if you see them in an adult, that's a bad sign. Are they, what's their posture? What's their, do they have to sit up to breathe? Are they laying down? Are they comfortable? Do they appear short of breath? You're also going to hear me use the term air hunger a lot this semester, where does it look like they are just really struggling to breathe, that they're working hard to get oxygen? Are they air hungry? Do they look panicked? Is the chest even? Is both sides equal? Are they rising and falling at the same pace? Are they using accessory muscles? Do you see the shoulders lifting as they're trying to take a deep breath? Are there any deformities or tracheal deviation? Is there anything obvious when you walk in the room, when you look at that patient? Is there anything that jumps out at you and says, hey, this isn't okay? I cannot emphasize this enough, you guys. When we get into clinical, it is so important for you to do that initial assessment and get a good baseline, and that means look at your patient. Talk to them, yes, but look at how they are breathing. Look at their pattern. That's your baseline. And then later through the day, when you go back into the room, you would immediately be able to notice if that pattern is different. And in these patients that we're going to be taking care of in clinical this semester, a lot of them have advanced respiratory issues, and those subtle changes are going to be very important clues in that patient's condition, whether they're getting better or whether they're getting worse. And it's very important that we pick up on those things before the patient even tells us they don't feel good. We can often sense these changes or see these changes just in their inspiratory pattern and their work of breathing. Of course, auscultation is very important. You've got to listen to them after you assess their their work of breathing and their effort. Listen to the lung sounds. You've got to listen in all fields, all lobes, upper, middle, lower, and on the posterior side, anterior and posterior. If you really want to know what a patient's breath sounds are, you've got to listen skin, on the skin, not through the gown, and front, back, top to bottom, okay? You're listening for all of the sounds. You're ultimately want to make sure that there's air moving equally in all lobes, upper and lower, front and back. Or is there an area that is diminished or absent? Also, you want to make note if your patient has stridor, if they're wheezing, if they have just an abundance of crackles, which would be fluid. So you really want to make note of what they sound like. Again, baseline assessment is vital. You will go back through the day and listen to your patient again, or you should, and make note of any changes. Auscultation is not something we do just at the beginning of the day. It's something we do throughout the day. In this semester with these patients, they're going to change. And so we've got to be assessing them throughout the day. There are times when you will palpate your patient. Tenderness, a lot of times the palpation will come as you're auscultating. You can tell when you put the stethoscope down, you can tell if the patient grimaces or if there's a sore spot. So that sometimes will go hand in hand. If they have obvious deformity or trauma, then you might actually, palpate with your fingers. Also going to be listening or assessing for subcutaneous emphysema, which we will talk about a little bit more later. But it is a very distinct disorder that you will be able to pick up on with palpation. Endotracheal intubation. We talked in the beginning about non-invasive methods of oxygen delivery, and now we're shifting to invasive method of oxygen delivery, and that is via endotracheal intubation. That means that we are actually going to put a tube, placement of an endotracheal tube into or through the trachea into the airway for the purpose of breathing for the patient and to help remove secretions that maybe they can't clear themselves. Okay, the bottom line for placement of an endotracheal tube is that it is placed when we know that the patient cannot protect their own airway, or we are afraid, we see reasonable evidence that they are going to lose the ability to protect their own airway. So it's an artificial means of breathing for them, okay? Now, we don't just intubate people just because we feel like it. Doctors put a lot of thought into it, and it's really, sometimes it's a preventive or a preemptive thing, and sometimes it's done in an emergency setting when the patient is not breathing at all. But in either way, the patient has lost the ability to protect their own airway, and so we need to do it for them. So that would be indications for endotracheal intubation. The way that the tube itself is structured, at the end of it, it has a little balloon that's inflated with air. It's called the cuff. And once the tube is properly positioned, which it is not within the scope of practice of a basic registered nurse to put in a breathing tube, that is something that has to be, that's a skill that has to be attained through advanced cardiac life support, and then you have to be familiar with your facility policy and procedure. But once it's placed, the tube is inflated, or I'm sorry, the cuff is inflated with air to hold it in place, and the cuff sits right about the larynx. And so once that cuff is inflated, that balloon actually inflates, and it kind of seats itself in the larynx, and it holds the tube in place to keep it from being dislodged. So that's your purpose of the cuff. Now, some complications related to the cuff if it stays in too long or if it's overinflated, it puts too much pressure on the larynx and it can cause tissue necrosis. It can actually, in some cases, if it's misplaced or left in too long, it can impair long term. It can cause vocal cord damage. If you remember, the way the anatomy is naturally, the glottis, whenever we swallow, you have a glottis that closes over the trachea to block any kind of food or secretions from going down into the lungs. That's normal. It separates the esophagus from the trachea. When we intubate the patient, it prevents that glottis from closing the way it would naturally. So a patient who is intubated has to be NPO. No ice chips, no water, no food, no nothing, because that opening is always open. So anything that we would give the patient by mouth is going to go directly into the lungs as opposed to into the esophagus. So all patients who are intubated are NPO. That cuff pressure is assessed every shift. It's typically done by respiratory, and they are required to document the pressure of the cuff. It's done whenever the tube is placed. They make note of the level where the tube is in terms of the depth of it, and there are some markings on the ET tube itself that tell us how many centimeters advanced that tube is into the trachea. And then after they inflate the cuff, they will measure the pressure, and they'll make note of how much pressure is in that cuff. And why is that important? Because every day when they assess it, they're going to make sure that it's at least the same amount of pressure. Not more, not less. If it's more, it can cause injury. If it's less, it can cause the tube to become dislodged. So those are all important things that we need to be aware of, and even though we may not be doing it, we're still responsible for knowing that it gets done and that the pressure's the same. Sometimes when the cuff pressure gets low, that cuff begins to deflate and you can actually hear air escaping around that cuff, and it sounds like a hissing sound or a gurgling sound coming from the patient's throat. And you definitely shouldn't hear that. Patient assessment related to care of the patient on with an endotracheal tube. If you look at page 505, chart 21-7, it's got a lot of information there about patient assessment related to endotracheal intubation. Make sure you're very familiar with those things. Breath sounds, settings of the ventilator, safety precautions, things like that. Make sure you're very familiar with those things. There's always a risk for injury and airway compromise from tube removal. If we have put that tube in, we put it in for a purpose. If it comes out before we're ready for it to come out, then a lot of times what that means is that if the patient pulls it out, or if it becomes dislodged with turning or traveling. So continuing to talk about if that endotracheal tube becomes dislodged, inadvertent removal, again, that could be from turning the patient, moving them around, or if they had to go like to CT scan or someplace like that, if they had to actually travel to a different place, that tube can become dislodged. And if the tube comes out and we have not deflated the cuff, then it can cause airway swelling, it can cause inflammation, and those things would make it very hard or more difficult to get the ET tube back in place. And of course, if the patient can't maintain their own airway and we can't get another tube in, then that would lead to decreased oxygenation. It can lead to hypoxia. and that can eventually cause the patient to deteriorate. So it's very important that we assess for placement of that ET tube, that we assess to make sure that, wherever it was, however many centimeters it is at the lip, where it's taped in at the patient's mouth, that it stays there. Chest x-ray is also the gold standard today for verification of placement of that ET tube. Anytime an ET tube is placed, then a chest x-ray will be done immediately after to verify placement. Some other complications of improper placement, you have to listen to breath sounds. Once it's placed, you listen to breath sounds, and if you were to hear maybe breath sounds only on the right side as opposed to breath sounds on the left, then if you remember the anatomy, you have a right main stem bronchus, and that is the natural way that the ET tube will track. It will naturally track down the right main stem. So if it's advanced too far, it's going to go into the right main stem, and you will only hear breath sounds on the right side. You won't really hear any breath sounds on the left side. And at that point, then the ET tube needs to be pulled back above the bifurcation, and get it out of the right main stem and get it back up above the bifurcation of the bronchus, so that it will we'll be able to oxygenate both lungs. As soon as you withdraw it, or the doctor or whoever, again, it is not within our scope of practice to manipulate that tube. Respiratory or the doctor, somebody will do it, will pull it back some. And then you would reassess, reauscultate, and you should be able to hear breath sounds on both sides. Another verification tool that you will see used a lot of times in the hospital is a CO2 detector. They'll put that on the end of the ET tube once it's been placed, and this is an initial placement. We're talking about placement verification. Once it's been placed, they're going to put a little CO2 pod on the end, and as they bag the patient, as the patient exhales, they should be blowing off CO2, and that little pod will pick up on that CO2 and it'll change color. And it should be yellow, I think well, it depends on the type of device that you're using, but they all have little ways to indicate that we have positive CO2 return. And that's an indication that we're in the lungs. Other than auscultation of the lungs, you can auscultate over the stomach. If you hear air gurgling or moving in the stomach, or you don't hear, especially if you hear it in the stomach region and you don't hear it in the lungs, then that can be an indication that that we intubated the esophagus rather than the lungs. And the tube would need to be removed and then replaced. But again, that is the gold standard for verification is chest x-ray. So there should always be a chest x-ray done to verify placement. You will see signs in your patient that if the tube is not placed correctly, their saturation, O2 sats, will not elevate. They will be low. The patient might become bradycardic. There's physiologically, those are the things that you're going to see. Blood pressure may start to fall, but ultimately they're going to be bradycardic and their sats will be low. Their color might also be bad. They might become cyanotic. Those are all signs of hypoxia. You will also see those same signs if that tube becomes inadvertently dislodged. Now that doesn't mean the tube would come all the way out, but it might just mean that it has been pulled out enough that we're not able to oxygenate the lungs effectively. And so you would, again, your saturations would drop, heart rate might start to fall. Initially, the patient might become tachycardic as they become a little bit hypoxic, but as that hypoxia increases, then, because remember, when oxygen levels are getting low, CO2 levels are getting high. So your patient's level of consciousness might change. Their heart rate might initially be elevated, but then it will begin to fall. Blood pressure might begin to fall. Initially, if the patient is not totally sedated, if they're hypoxic, they're going to be anxious and restless. And then over time, as that hypoxia increases, their level of consciousness will begin to deteriorate. So the main point here is that we want that tube to stay in place. We don't want it to become accidentally removed. We don't want the patient to pull it out. So you have to be very aware of your patient's cognitive state, their ability to follow commands. Sometimes intubated patients will be restrained to keep them from pulling at their tube. We don't tie people down anymore the way we used to. When I was working in ICU, anybody that had an ET tube, they automatically got wrist restraints. And we don't do that anymore. If the patient is awake and cooperative, only lightly sedated, then we may not put them in restraints if we know that they're going to not pull at that tube. When you move your patient or transport them to somewhere for a test, or if you're turning for a bath or whatever, you must make sure that that ET tube stays in the proper place and that it hasn't become dislodged. Because again, remember, if it becomes dislodged with an inflated cuff, then that can lead to airway swelling, tissue inflammation, which can make it difficult to get the patient re-intubated if we need to. So we always want the tube to be removed with a deflated cuff under controlled circumstances. A tracheostomy is another method of invasive oxygen delivery. I know y'all went over tracheostomy and tracheostomy care in fundamentals. So just a little review. It's meant to bypass all of the upper airway structures. Might be because of an obstruction, might be because of thick secretions. It might be that we need long-term mechanical ventilation. The book, I think, talks about anything greater than 3 weeks. Mechanical ventilation greater than 3 weeks, they're going to get a tracheostomy, but newest research, the newest standards to date say that if the patient is going to require mechanical ventilation longer than 7 days, then they need to be evaluated for trach placement. So, that's definitely something, long-term mechanical ventilation. If the patient is not able to maintain their airway in the sense that, when they swallow they're going to aspirate, then a lot of times we will evaluate them for trach placement. If they've had massive facial trauma and we can't physically get an endotracheal tube in, either orally or nasally, ET tubes can be placed nasally. That's another option other than orally. But if we can't get a tube in either nasally or orally, then they will be evaluated for tracheostomy placement. Complications of trachs, bleeding, of course, because it is a surgical procedure. Pneumothorax is also a potential complication because we are working in the lower larynx area, in the apices of the lungs are very close, and so there is a possibility that during the procedure we could puncture the lung and cause a pneumo. Aspiration is still a complication, just like with endotracheal tube, because again, we are preventing the glottis from being able to close, and so anything that the patient takes in by mouth is going to go straight into the lungs. Subcutaneous and mediastinal emphysema, that's just leakage of air from either positive pressure ventilation, it's forcing air into, or it's escaping from the lungs and it goes into the sub-Q tissue. We'll talk about sub-Q emphysema later. Laryngeal nerve damage, and then tracheal wall penetration. Because we are placing surgically, and it's an incision, we're making cut, then there is the possibility of cutting that laryngeal nerve and then penetrating the trachea as we insert the cannula of the tracheostomy. Then there are those potentials for complications. Long-term complications: airway obstruction, infection, innominate artery rupture, dysphagia, fistulas, tracheal dilation, ischemia, necrosis, kind of some of the same complications as with intubation. Tracheal dilation over time, the trachea is held in place by a cuff just like an ET tube is. And remember, a tracheostomy or trach placement is for long-term mechanical ventilation. And so this patient is going to have this cuff inflated over a long period of time. And as that happens, the actual tracheal tissues will dilate or enlarge, and so it requires more and more and more air in that cuff to hold the trach in place. But the more air we put in the cuff, the more the trachea dilates or enlarges, and so it's kind of a vicious cycle. But we have to do what we have to do to keep it in place. So, and again, over time, if it's overinflated, then it can cause ischemia and necrosis of those tissues. So those are all things that you would definitely want to assess for in a patient who has a tracheostomy. There's just a review pictures of what a trach tube looks like. Y'all go back and brush up on trach care. We did that in fundamentals. You might actually be doing trach care this semester if we have patients who have tracheostomies either in the unit or on step down, so make sure you brush up on how to do that. Nursing management of a patient either with an ET tube or a tracheostomy. Some of the things that we as nurses are going to be doing to take care of these patients: suctioning. Go back and brush up on tracheal suctioning. You were taught that initially in fundamentals. Hyperoxygenate. How long do you have to pass that suction catheter before you have to stop? Go back and review your techniques from fundamentals and make sure that you're familiar with how to do that. Suctioning of an ET tube, that's something that you will see in clinical. Again, those suction passes are going to be the technique of actually pre-oxygenating and how many seconds you have to pass that suction catheter is roughly the same as with a trach. So that would apply with ET tubes as well. Cuff management, again, we check those pressures according to facility policy and procedure. The recommendation is Q shift. That might be Q8 hours, it might be Q12 hours. It depends on facility policy. Recommended pressure management is between 15 and 25 millimeters mercury for optimal cuff inflation to keep the tube where it needs to be without causing any damage. Monitoring for complications. Make sure you review that chart on page 507. We've already talked about a lot of the complications. Patient and family teaching points. Important things that you really want to go over with them for a patient with an ET tube or a trach is, number one, communication. They're not going to be able to talk to you with an ET tube or with a trach in place because we pass those through the vocal cords and there's no way for them to talk. So communication is an issue. We have to come up with other ways to communicate with the patient, either written or communication board or reading lips or, however that may be. We've got to find a way to communicate with the patient and teach the family how to communicate with the patient. We also have to remind the patient and family that the patient must be NPO while they have an ET tube and a trach. They cannot have anything to eat by mouth, and that includes ice chips and water because they'll aspirate. Home care points, we've got to teach the family how to do trach care, infection prevention techniques when they're home with a trach, sterile technique doing trach care, keeping secretions cleaned off, keeping them clean around their trach ties, changing those out periodically, how to change it out without having it become dislodged, signs and symptoms of infection to watch for, and when to report those signs of infection. We need to teach the family about possibly needing increased cuff pressures over time. If this is a long-term trach management at home, then they need to be aware of signs of it being dislodged, signs of hypoxia. All of the things that we would assess for in the hospital, we need to teach them to assess for at home. Mechanical ventilation. So let's talk a little bit about mechanical ventilation. There are different types of mechanical ventilation. Overall, mechanical ventilation is used to control the respiratory rate in certain situations, things like surgeries, injury, head injury, anything, again, where the patient can't maintain their own airway or they're just not breathing effectively. Then we're going to not just place an ET tube, but we are going to mechanically ventilate the patient, meaning we're going to breathe for them. So indications would be to control the respiratory rate in a certain situation like surgery or head injuries, or to improve oxygenation when the patient can't maintain their own respiratory rate. And then a third indication is going to be when we want the patient to rest. It will allow us to, or allow the patient to rest their respiratory muscles and allow them to heal and conserve energy. Let's say they've been really sick and they've had to work super hard to breathe, to maintain good oxygenation, and it just wears them out. And so those would be the three reasons why we would mechanically ventilate a patient. Mechanical ventilation can be positive or negative pressure. The most common thing you're going to see in the hospital is positive pressure. Usually negative pressure, that's an old way. It's called that iron lung. Negative pressure is not good for acute illness, meaning in the hospital with a quick onset type thing. Most of the time your negative pressure ventilators are long-term. They're used for long-term ventilation, usually in patients that have neuromuscular disorders. They're used at home a lot of times. The patient doesn't need to be intubated for a negative pressure ventilator, so they're pretty easy to use. It's just a machine that's going to exert negative pressure on the outside of the chest, and kind of it most closely simulates normal respirations, because our normal respiratory pattern is negative pressure in nature. It's a negative pressure environment. So these negative pressure machines, although they won't be used in the hospital setting, they do most closely resemble normal respiratory pattern. Positive pressure ventilation, some reasons that we're going to use positive pressure. A patient who has persistent acidosis, meaning their O2 level is low and their CO2 level is elevated, they're acidotic, their body is not able to compensate this acidosis in a normal way. And we know that with persistent acidosis, with continuing to lose oxygen in the bloodstream and increase our CO2 levels, the patient is going to end up in respiratory failure. And so that is a primary indication for positive pressure ventilation. Okay, so positive pressure is the most common form of intubation or ventilation, and it's what you're going to see in the hospital. There are different types of positive pressure ventilation, and we're going to talk about three of them: the pressure cycled, time cycled, and volume cycled. Now what this means is positive pressure means that we are actually forcing air into the lungs. We're forcing the alveoli to expand on inspiration, and expiration is a passive process, which is normal. Typically, getting air in the lungs takes effort, and getting air out of the lungs takes no effort or no energy. So with positive pressure ventilation, we are actually forcing air into the lungs on inspiration, and then expiration is passive. the patient has to be intubated or they have to have a trach in place for us to do positive pressure ventilation. Non-invasive methods of positive pressure ventilation would be use of a mask, an ambu bag, and a mask that goes over the face. CPAP and BiPAP are excellent examples of non-invasive methods of positive pressure ventilation. So we'll talk about those. We'll talk about those in just a minute, but I want you to understand that methods of positive pressure ventilation, pressure cycle, time cycle, and volume cycle, those are going to be the three that we talk about. And basically what that means is you're looking at how the inspiratory phase ends. There has to be an inspiratory phase and an expiratory phase. And the machine has to know when the inspiratory phase is done and when to begin exhalation. So with pressure cycled ventilation means that airflow is forced in, airflow is delivered until a preset pressure is reached inside the chest. And once that pressure is reached, then inhalation or inspiration is ceased and it automatically moves into the expiratory cycle. Time cycled means that the length of the respirations or the length of inspiration is controlled, and there is a specific volume of air delivered over a specific amount of time. Time cycled is almost exclusive to newborns and infants, okay? But so you might see it in NI, or once you get into OB, if you're in the newborn nursery or something like that, you might see time cycled in that setting. But it is the length of respiration is controlled over a set amount of time. Once that amount of time is up, then we move into expiration. Volume cycled means that a volume of air is a preset volume of air is delivered, and once that volume of air is delivered, no matter how long it takes it to get in or how short it takes it amount of time for it to get in, once that set volume is delivered, then expiration begins, and expiration is a passive process. Volume cycled is the most common type used in adults. It's what you're going to see most commonly in the hospital. So again, types are classified by how the inspiratory phase is ended, pressure cycled, volume cycled, time cycled being in newborns and infants. Non-invasive methods of positive pressure ventilation. As I had said a minute ago, we use a mask or another form of non-invasive device to get a seal and permit positive pressure ventilation. These are going to be used in patients that don't want to be intubated. A lot of times it can be an end-of-life issue where the patient has said they have an advance directive and they have said that they do not want to be intubated. It might be because they're so sick, their lungs are so sick that we know if we put them on a ventilator, if we intubate them and put them on a ventilator, that they will not ever be able to be weaned off that ventilator, and they have chosen not to do that. Or we can also use non-invasive positive pressure ventilation in cases of sleep apnea. This would be your CPAP machine. Patients can sleep with a CPAP machine, and it will help keep that airway open at night while they're asleep. So let's talk about the differences between CPAP and BiPAP. Okay, we've talked about indications, so let's talk about the differences between the two. CPAP is continuous positive airway pressure. Okay? It's one type of non-invasive positive pressure ventilation. The patient will get continuous, constant pressure throughout the whole respiratory cycle. With CPAP, the patient breathes on their own. They have to be able to maintain their own airway and breathe on their own, which means they have to have their own respiratory effort. They have to be initiating effort on their own for CPAP to be effective. If they don't have spontaneous respirations, if they don't have their own independent inspiration, expiration effort, then CPAP is not going to work. CPAP does use a leak-proof mask. It has to have a good seal because there's such high pressure that if there's not a good seal, it's going to leak out around the mask. CPAP is really good at forcing the alveoli open. It prevents alveolar collapse, which can lead to respiratory failure. And CPAP is most effective in patients with obstructive sleep apnea. So in patients that are known to have sleep apnea, or when you assess them, if they have that physical characteristic, thick neck, they snore, you can tell that it looks like they have some sleep apnea, but they're sleepy, maybe they're sedated from medication or they're just out of surgery, then CPAP is going to be a really good option for them because it will force air, it'll force oxygen into the alveoli and prevent those alveoli from collapsing. But the patient can still have their own inspiratory effort, expiratory effort. Okay? BiPAP is different. It's bi-level positive airway pressure, meaning we have independent control or independent settings of the inspiratory and expiratory pressures. Okay, it gives continuous pressure support. It gives a continuous amount of support throughout the entire respiratory cycle, but inspiration and expiration pressures are a little different. BiPAP is best suited for patients who have very little or absolutely no independent respiratory effort. So these are patients who really aren't maintaining an airway well on their own. Their respiratory effort is very poor, and they need help, but we aren't quite ready to intubate them yet. So BiPAP is actually the very last step that you might see used before we intubate the patient. Now, why would we want to use BiPAP as opposed to intubation? Well, BiPAP is non-invasive. And if one thing you need to always remember is that we do the least invasive method first, if at all possible. Now, how do we decide who gets BiPAP and who gets intubated? Well, it largely depends on, if you go back to the indications of mechanical ventilation, whether or not they're acidotic. If the patient, and not just if they're acidotic, but why are they acidotic? If they're acidotic because they've been sleepy or oversedated, then we might put them on BiPAP and let them breathe, let them breathe off that CO2. And then maybe they'll wake up and they'll be okay. If the acidosis is from another reason, it's from chronic illness, it's from acute respiratory failure that's not likely to turn around quickly, it's from infection, it's from renal failure, it's from something that's going to take longer to resolve, then they'll go ahead and intubate those patients. But if the acidosis seems, if we think that we can turn it around in a fairly quick amount of time, then they'll try BiPAP first because it's least invasive. But the big differences here between CPAP and BiPAP is CPAP, the patient has to have their own respiratory effort, or CPAP will not be effective. BiPAP can be used in a patient who has little or no effort because we control inspiratory pressure and expiratory pressure. it more closely resembles normal respiratory pattern. So with both of them, you're going to have an oxygen setting. Your doctor should tell you they want 100% FiO2, which is the fraction of inspired oxygen, 80%, 50%, whatever percentage of oxygen they want the patient to have. And then with CPAP, you will have a pressure setting, and that's it. So you'll have an oxygen percentage and a pressure setting. On BiPAP, you're going to have an oxygen percentage, a pressure setting, and then you will have an inspiratory rate and an expiratory rate, or an IE ratio. And it'll be something like 10/6 or 12/4 or something to that effect. So typically you're going to see, in terms of on the continuum of oxygenation, from very, very least amount, of course the least amount of oxygen is room air, and then nasal cannula, then venturi mask, then non-rebreather or face mask, face tent. And then from a non-rebreather, because remember, non-rebreather and face tent are those high flow, almost 100% oxygen. From non-rebreather, then we would move to BiPAP. And then if BiPAP doesn't work, then we are going to move to intubation. So that's kind of the pecking order or the progression on that continuum of oxygenation. Once they're intubated, then the ventilator is going to be set to a specific mode of air delivery. These modes are how the breaths are actually delivered to the patient. There are a lot of different modes out there, and our goal in this class is not for you to be just the foremost expert at ventilators. I just want you to have kind of a brief introduction to it so that you're familiar, okay? So what we're going to talk about here is from the greatest amount of support or the greatest amount of help from the ventilator to the least amount of help, okay? So assist control is going to be the greatest amount. IMV, SIMV is going to be kind of in the middle, and then PSV, which stands for pressure support ventilation, is the least amount of support from the ventilator. So if you can think of it like that, from greatest to least, then I'm going to explain a little bit of this as we go. But assist control ventilation basically is full support. This is the mode that we use when we want the patient to rest. We don't want them to really do any work at all. We want the machine to do all of the work so the patient can rest and heal and conserve their energy. Y'all, it takes a lot of energy, physical calorie requirements to breathe under normal circumstances. Inspiration takes effort. Expiration is passive. But if there are physical conditions or, physiologic problems that make it harder for air to get in the body, then the body has to work harder. It takes more energy, more calories to take in air. And so that burns more calories. It burns more energy. By the same token, if there is a condition that prevents expiration from being passive, particularly COPD, emphysema, or asthma, then the patient has to work. They have to put forth physical effort to exhale air out of the lungs, and that takes calories. That takes energy. So if the patient is burning calories, inspiring and expiring, then they're burning double calories. And those calories, instead of being used to heal, instead of, being able to heal the body, those calories are going nowhere except to breathe, to maintain respirations. So it's very important that if the patient is in a very critical situation, that we do all the work for them, that we relieve them of that effort and let the machine do the work for them. And that's what assist control is for. It's full support. It's a preset volume of air, a preset respiratory rate. The patient, with ventilator modes, we can dial in a number of breaths. We can dial in and tell the machine, give the patient 15 breaths a minute and give them a tidal volume of 500. Every time you give a breath, it needs to be a full volume of 500. Now, the machine will do what it's told. The patient is going to sometimes do their own thing too, because it's a natural response to want to breathe. So sometimes the patient will breathe on their own in conjunction with the ventilator. With assist control mode, the patient has the ability to take a spontaneous breath if they want to, but when they take that breath, the ventilator will give them whatever that preset tidal volume is. And there's no coordination between the breaths that the patient takes and the breaths that the machine gives. So if the machine gives a breath, the patient's going to get 500 tidal volume, and then all of a sudden the patient initiates a breath, they're going to get another 500 of tidal volume on top of it, and that can actually be harmful to the patient because we can be overinflating the lungs. So on patients that are on assist control, they really need to be sedated, and sometimes they'll be paralyzed so that the machine will do all the work and the patient doesn't trigger their own respiration. With IMV or SIMV, IMV stands for intermittent mandatory ventilation, and SIMV stands for synchronized intermittent mandatory ventilation. You won't really see IMV very much anymore. All you see is pretty much SIMV, which is synchronized, and that means that it's synchronized to the patient's own respiratory cycle. They get a preset tidal volume from the machine, and we can dial in a preset number of respirations per minute. So just like with assist control, with SIMV, they're going to get, let's say, 15 breaths a minute in their tidal volume of 500. The difference with SIMV and assist control is, with SIMV, if the patient initiates a breath on their own, the ventilator shuts off. It does not force in that preset volume of air on the patient-initiated breath. So the machine might deliver 15 breaths a minute at a tidal volume of 500, but let's say the patient wants to breathe 5 or 6 times a minute on their own. They will be able to breathe those 5 or 6 times per minute, and they will pull whatever tidal volume they are capable of pulling. It might only be 200 or 300 mils of air, but that's okay. The machine doesn't force anything else on them. So that synchronized part means that the machine breath stops or cuts off whenever it senses a patient-initiated breath. So it doesn't help that patient-initiated breath. It just senses it and stops so that we don't overload the patient. Okay? So synchronized is better for the patient. Now, a synchronized SIMV is used in patients who are somewhat awake we don't want them totally sedated, and we definitely don't want them paralyzed, because we want them to be able to initiate breaths on their own. We want to see, we're going to use SIMV to see what the patient's effort is. They're not ready to come off the ventilator, but we just want to know what their own spontaneous effort is. Pressure support ventilation is the smallest amount of help, the smallest amount of support from the machine. This is the setting where the patient really does all the work. Instead of having a set respiratory rate and a set tidal volume, there aren't either one of those. The respiratory rate is all spontaneous from the patient. The tidal volume is all spontaneous from the patient. The only help that the patient gets from the machine is what we call pressure support, which is just enough pressure to overcome the amount of effort that it takes to breathe through the tubing. So when a patient is intubated and on a ventilator, of course, they have the ET tube in place, and then there is that actual tubing, corrugated tubing, that goes from the ET tube to the machine that the air flows back and forth through. Well, it's like trying to breathe through a garden hose. The longer it is, the more effort it takes to overcome the resistance in that tube, and it takes effort from the patient. Well, on pressure support ventilation, we really want the patient doing all the work, and we don't want to tire them out having to move air back and forth through that tubing. So we can dial in a certain amount, a very low amount of pressure called pressure support to negate the resistance of the tubing. So it kind of puts that patient on a level playing field. So we're helping them overcome the resistance of that actual corrugated tubing, but we're not giving them any more support beyond that. So all the effort comes from them. And that's the last step. Typically, pressure support is the last step, or the last setting that they're going to be on before we extubate them. It tells us what their respiratory rate is going to be on their own, what their tidal volumes are on their own, and we can see, are they going to tolerate breathing on their own? Are they going to tolerate being extubated? Or if they're still weak, if they're still not pulling a deep enough tidal volume and we don't need to extubate yet, that it all gives us good indication of how ready the patient is to be extubated. As a nurse, there are going to be some very specific things that you are responsible for in terms of monitoring and caring for a patient on a ventilator. There's some very specific assessments of the equipment that we are responsible for. And then as far as adjustments being made to the ventilator, there's some very specific things that we have to know as nurses. First and foremost, the settings. We're responsible for knowing what the correct settings are. Now, your settings come from physician order. They have to write an order that tells you what ventilator mode that they want the patient to be on, what respiratory rate they want, what tidal volume they want, if they want any pressure support added in, dialed in to help overcome that corrugated tubing. And then we can also dial in PEEP. I didn't talk about that with those other ventilator modes and settings, but we can also dial in PEEP, or positive end expiratory pressure, to help overcome or to help prevent atelectasis. So as the nurse, you are responsible for verifying your MD orders and making sure that the ventilator is set properly, that the the settings that the doctor ordered or the actual settings that are in place. Now, in terms of functioning, proper functioning of the ventilator, it should always be plugged into a red plug or whatever plug is on a generator, because if there is power outage, you certainly don't want to lose power to your ventilator. And then you're responsible for being aware that it is, providing air, that inspiration and expiration are happening the way they're supposed to. Okay? We don't do maintenance on these machines, but you can, it's like anything else. You know when an IV pump is not working right. So it's your responsibility to know that the machine is functioning properly and that the correct MD orders are in place. So you should know also things like the tidal volume. You should have a relative idea that the tidal volume that's been ordered for your patient, is it safe? I told you before that normal tidal volume is 10 to 15 milliliters per kilogram. So if you have a patient who only weighs 90 kilograms, or let's say 100 kilograms, well, that would be 200 pounds. Okay, so roughly 100 kilograms. If we did 10 mils per kilogram, that's a tidal volume of what? You figure it out. Okay, so if your patient weighs 50 kilograms and you want to do a tidal volume of 10 mils per kilogram, so again, do the math, 500. So what I'm telling you is that if you have a very small patient and you have a very large tidal volume, you need to question that. There's nothing wrong with asking the doctor why he chose such a high tidal volume on a small patient, because ultimately high tidal volumes in small patients can cause pneumothorax. So, just think, FiO2, your patient, let's say that they're on 100% FiO2 when we put the breathing tube in, and then their ABG looks normal and their SATs are good. It's our responsibility to maybe ask if we can reduce that oxygen to a lower level, because we know that it is not healthy to leave somebody on 100% FiO2 for a long period of time. So those would be some things that we are responsible for making sure are addressed. Another thing that we are definitely responsible for assessing is whether or not the patient is in sync with the ventilator. Is there a nice even flow of inspiration and expiration, or does the patient seem to be fighting against the ventilator? Do you hear choppy breaths, choppy sounds? Are there a lot of alarms going off? Most ventilators have what they call peak pressures or pressure limit alarms, and that means that when the pressure inside the thoracic cavity becomes too high, beyond a safe level, the machine will alarm. And that's a sign that we need to come see, why is the pressure elevated? Do they need to be suctioned? Are they coughing? Something's going on. So you just need to make sure that you have to assess, you have to do a physical assessment and make sure that the patient's respirations are in sync with the vent and that they're not really fighting against it or working against what the vent is trying to do. Also responsible for looking at the condition of the tubing from the patient to the ventilator, making sure it's not kinked off, make sure that there's not water in that tubing. Ventilators are humidified, and so occasionally there can be water, that condensation that collects in the corrugated tubing, and so it's our responsibility to keep that water drained out of there. if the tubing looks worn, or if it for some reason became kinked or cracked, there would be a leak of air, and so it would be our responsibility to notify respiratory and have that changed. We're also responsible for monitoring alarms on that ventilator, and so because we're the ones that are with the patient on a continuous basis. So if there are alarms that are continuously going off, then we need to be notifying respiratory therapy and let them come. Could be that alarm, again, a peak pressure, or um, um, a pressure alarm. Maybe we just need to suction the patient. Sometimes they'll have a mucus plug, and that will make the ventilator alarm because there's not good airflow in and out. So we just have to be aware. If the alarms are going off, you have to go check it out, see what it is, and then call, appropriate, usually respiratory. You really need to be aware of your facility policy and procedure. In a lot of places, nurses are not responsible for setting up and adjusting the ventilator. That is a respiratory therapy job. Some facilities will let nurses do it and some won't. So as long as you are following the physician's orders, the state board says that it is within your scope of practice to adjust a ventilator. You just need to make sure that your facility policy allows you to do that. And in any case, you need to make sure that you are following the physician's specified orders. So, that's the bottom line, is what is the facility policy and what are the doctor's orders. As far as monitoring the equipment, again, just making sure that it's plugged in where into like a red plug or something that's going to be on the backup generator in case there's a power failure. We talked about the peak pressure alarms, and then the other alarm that I didn't mention is a decrease in pressure or a decrease in air volume. That could be like an air leak. If I talked earlier about the cuff on the ET tube. If air is leaking out around that cuff, there's not a good seal, then the ventilator detects a loss of air and it will alarm. Also, if there is a loss of pressure for some reason, remember this is positive pressure ventilation. And so we are delivering a certain amount of pressure, of air pressure, into the patient's lungs. And if there is a loss of that air pressure, then the machine will alarm. So, that might be a pneumothorax. Usually it's something like that. A loss of pressure is going to be a pneumo, or a loss of volume is going to be an air leak. Okay, so those would be other areas that we definitely would need to assess for. Nursing process. When we talk about nursing process, or starting with assessment of our patient, of course, it's a head to toe. We're not just looking at the lungs just because they're intubated. We are going to do a full head to toe assessment, all body systems, but a very in-depth respiratory assessment, as well, because they are on mechanical ventilation. So that includes the ventilator settings, the patient's response on those ventilator settings. What are their O2 saturations? Are they triggering any spontaneous breaths on their own, or are they solely dependent on the ventilator and not breathing above the set rate of the ventilator? Signs of perfusion. Do they have good cap refill? Do they have good color? Are they cyanotic? Do they look comfortable? Are they restless? The first sign of hypoxia is restlessness, agitation, and then mental status changes. in that order. Your patient will be very restless, and then they will become agitated, and then they will become start to have mental status changes. So it's hard to decipher mental status changes when they're intubated because they can't talk to you, but they will be restless. So do they look comfortable to you? Do they look like they're breathing easily? If they are not completely sedated, you have to assess coping mechanisms. How are they doing? Do they appear anxious? Are they fidgety? Are they picking? Are they pulling at things? Or do they follow commands? Do they interact with you? Do they make eye contact with you? Do they look scared? Are they crying? There's a lot of things that you can assess without ever having to talk to the patient, which brings me to communication. They won't be able to verbally talk to you, but there are other ways to maintain lines of communication. So you've got to establish a very good communication line with the patient, especially if they're not sedated. Then you really want to be able to communicate with them, whether it's writing or, sometimes they'll mouth things around that, they'll be able to mouth it with their lips and you can understand what they're saying. So, nod your head once or blink once for yes and twice for no. I mean, whatever works. But communication is very important. So again, when we're looking at, physical assessment, you're looking at the depth of respirations, you're looking at chest symmetry, O2 sats, breath sounds, their color, cap refill, and then looking for other signs of, things that make you know that they're comfortable and that they're coping, and then evaluating their communication. We may have to do some troubleshooting on a ventilator. If you look at page 515 on that table 21.2, it talks about troubleshooting of the ventilator. Generally, patient problems that will be encountered are related to cardiovascular compromise or can be related to injury or trauma, barotrauma from the ventilator itself, or infection. Okay, so those are the three most common patient problems that you're going to run into. Cardiovascular compromise basically just means decreased cardiac output. Okay, poor venous return, decreased venous return because of the increased intrathoracic pressure. Remember, it's positive pressure ventilation. We are forcing air into the chest. So, and the chest is a negative pressure environment. So we're doing something that is counterintuitive to the body. And sometimes if the heart is sick, the heart can't take all of that positive pressure, and so it will decrease venous return into the heart, and it will actually reduce cardiac output. So cardiovascular compromise can be seen in your patient who's intubated, and that would manifest as decreased perfusion, decreased blood pressure, decreased heart rate possibly, but decreased signs of perfusion and cardiac output. Barotrauma or pneumo, that's another type of problem that you have to assess for and watch out for. And again, it's positive pressure related. We're forcing air into the chest. If the pressure that we're forcing in or the volume of air that we are forcing in is too great for the lungs to be able to handle, if the lungs are small, if they're fragile, if they're stiff, and we are forcing this air in, then we can actually cause the lungs to, we can pop a lung, we can cause a pneumothorax, and that's called barotrauma. The third and probably the most common issue with patients on a ventilator is infection. Recently, in the past few years, the Center for Medicare and Medicaid Reimbursement, or core measures is what it's called, have really focused on ventilator-acquired pneumonias. They say that a patient who comes in and they don't have pneumonia, we have to put them on a ventilator, and then they develop pneumonia. That's a ventilator-acquired pneumonia, and it is completely preventable, and we should have prevented it. Therefore, they will not pay for it. So that's a Medicare rule now. So anybody on Medicare, any patient who's on Medicare or Medicaid, if they come in and we intubate them and they end up with pneumonia that they did not have on admit or before they were intubated, then Medicare just says, okay, you did it. You know, we as the nursing staff did not take precautions to prevent pneumonia, and so now we made the patient sick, and now the hospital has to eat the cost of that care. So if you think about the population on Medicare, those are typically the older population who have lots of health problems. So it is extremely important that we first do a very thorough assessment of that patient upon admit, and that we document every condition that we see in that patient, so that if they do have a pneumonia on admit, that we have it documented. And secondly, once they are intubated, the whole process of intubation and then the whole time they are on the ventilator, we have to take strict precautions to prevent development of pneumonia. Okay? Well, how do we prevent pneumonia? Turn, cough, deep breathe, suctioning. In a ventilated patient, it's going to be positioning, turning Q2 hours. It's going to be humidified, making sure that the treatments are humidified, that the patient is suctioned on a regular basis, and oral care. Now, we've talked extensively about how the patient has to be NPO because anything that they swallow will go directly into the lungs. But that doesn't mean you don't clean their teeth, clean their mouth. You can brush teeth. You can use lemon glycerin swabs. You can use just a regular soft bristled toothbrush to brush that patient's teeth. Oral care is the #1 way to prevent ventilator-acquired pneumonia. So those are 3 of the big issues that we have to watch for and possible things that we might have to troubleshoot. You should always remember that if you find yourself in a situation with an intubated patient and you know that there's something wrong, the alarm's going off, the sats are dropping, you know that the patient is not ventilating, not being ventilated properly, you can always disconnect the patient from the ventilator and manually bag them with an ambu bag through the ET tube or through the trach, and that's fine. You can manually bag a patient at any point in time. There's nothing wrong with doing that. In fact, a lot of times, if the ventilator is having trouble getting air into the patient, if you will bag them with an ambu bag, you'll be able to feel that resistance, and it's probably something like a mucus plug or very thick, copious secretions that need to be suctioned. Once you get that taken care of, then your problem usually resolves. But just don't forget, when all else fails, get the ambu bag and begin to manually bag them until you can figure out what's wrong and get it fixed. With our diagnoses, continuing on with the nursing process, here are some of the diagnoses that are very applicable for a patient who has, a questionable airway, might be already intubated, might be, impending intubation, or someone who's on CPAP or BiPAP. So again, when you're working on those concept maps in clinical, if you have a patient who is on CPAP or BiPAP, here's a good list of nursing diagnoses that would be appropriate in that situation. All right, let's talk about interventions, things that we're actually going to do, okay, for the patient who's intubated. The first thing we're going to focus on is enhancing gas exchange. How are we going to do that? We're watching ABGs. A patient who is intubated typically will have an ABG done at least once a day, typically every morning, okay, because that is the best way to monitor our oxygenation level, the pH balance in the body. ABGs are the most accurate. So if you don't remember what a normal ABG is, or how to read an ABG, how to interpret it, you need to go back and brush that up from level 2. We will be looking at ABGs this semester. We will be looking at patients, some will be intubated and some won't be, but we will be looking at ABGs. And following the results of multiple ABGs to look at trends, okay? So that's one way that we can enhance gas exchange, is looking at ABG results and looking at other indicators of hypoxia, which are your physical assessment findings: color, cap refill, signs of perfusion, mental status, things like that. Another way to help to enhance gas exchange is to auscultate the lung sounds, okay? Baseline, once you come in the morning and you receive report, it is essential that you go get that baseline assessment. And then periodically, every couple of hours through the day on an intubated patient, you should be listening to their lungs. If they need to be suctioned, listen before, suctioned, listen after. You're listening for changes. So, a patient who has copious secretions that are difficult to clear is definitely going to alter gas exchange. Use of analgesics is a really good benefit for the patient. If you can just remember that patients in pain don't want to breathe. People who are hurting tend to hold their breath and splint, and they just don't, they're not relaxed. They don't breathe as effectively. And that can alter gas exchange and acid-base balance. So a lot of times you will have a post-op patient who's just come out of surgery and they're still intubated, and we've got to provide pain control for them. I mean, you can't just assume because they're intubated that they don't feel any pain. That's not true. So if you will medicate them and get their pain under control, then their breathing becomes easier, and their gas exchange and their pH balance is often much, much better. Got to watch for fluid volume excess or volume overload. So you have to be watching kidney function and output, making sure that they are putting out adequate amounts of urine, and that they're not becoming overloaded, because obviously fluid volume overload is going to alter gas exchange. Impairment of gas exchange, it can be multifactorial, so there can be a lot of different things that can alter gas exchange. So these are just a few things that come to mind, but it's very important that you assess your patient and you know what their baseline is, and then any deviation from that baseline needs to be addressed. Want to promote effective airway clearance. So again, that's assessment of lung sounds, suctioning, Other measures to clear the airway, which might be a position change. Mobility, we might want to sit this patient up in the bed. May not be able to get them out of bed, but maybe we can just sit them up in somewhat of a chair position. Humidification. CPT is always a good thing. Can't do incentive spirometry if they're intubated, but we surely can keep them suctioned out. We can do CPT and position change. We can do active range of motion, passive range of motion with them in the bed. And then medications, mucolytics, that's the main thing, is mucolytics to help break down all of the copious secretions, bronchodilators to help keep those airways open, and those in combination with the humidification will, humidity helps to liquefy the secretions, which, with mucolytics will help to be able to suction them out easier. Measures to prevent trauma and infection. Tube care. The ET tube should always be secured with a appropriate securement device so that it doesn't move around, it doesn't slip in and out. Every time that tube moves in and out of the trachea, up and down, there's a potential for infection. So we need to have a really good secure tube so that it limits the pulling and the moving in and out. Really the only time that you want to reposition or move an ET tube is if it's, first of all, if it's in too far, which would be right mainstem intubation if we'd want to pull it out, or if it becomes dislodged, it comes out too far, then we would need to call the appropriate healthcare providers and have it replaced if necessary. And then for people who are intubated for a period of time, often respiratory therapy will come in and they will move the location or the position of that ET tube from one side of the mouth to the other to prevent the tube from necrosing the lip. Because that ET tube does, it lays against the corner of the mouth or the lip, and after a few days it can start to cause skin breakdown. Now, generally, we don't leave people intubated longer than about a week without evaluating them for tracheostomy, but in some cases you will see them intubated for longer than that, than a week, so you really have to watch skin breakdown at the lip. Cuff management, we've talked about that. You're responsible for knowing when that cuff pressure is assessed and what the pressure is, and making sure that there is an adequate amount of pressure in the cuff. We are responsible for oral care or trach care. Again, this is the #1 way to prevent ventilator-acquired pneumonia, is to provide oral care or trach care if they have a tracheostomy. So brush up on your trach care. Keeping the head of the bed elevated is another way that we can prevent trauma and infection. Being mechanically ventilated is a very stressful thing. Again, the body's natural process is negative pressure environment, but we're providing positive pressure, which is not normal, so it's stressful. And so over time, a patient who's mechanically intubated and mechanically ventilated, they actually can develop gastric ulcers because of the stress of being intubated and ventilated. So one thing that we can do to help prevent this is to keep the head of the bed elevated at least 30 degrees. This helps to reduce any kind of reflux and prevent aspiration, especially if they don't have an NG tube to suction, or if they have an NG tube and we're giving them tube feedings through it, You definitely want to keep the head of the bed elevated at least 30 degrees. If they are receiving tube feedings through an NG tube, then they most definitely can reflux that tube feeding up, and then they would aspirate on it, because remember, there's no closing of the epiglottis. There's no protective mechanism. So anything that the patient refluxes, they're going to aspirate. So head of the bed up at least 30 degrees, and then anti-ulcer medications, typically going to be proton pump inhibitors for acid suppression to decrease the risk of stress ulcer formation, and to also to decrease the risk of aspiration. Other issues that or interventions that we need to make sure and implement with our intubated patients: mobility, range of motion, again, active or passive range of motion. Sometimes there are some physicians who want us to ambulate our intubated patients. So it's very important that we try to maintain physical mobility, because as the patient is on the ventilator, the diaphragm of an intubated patient atrophies very, very quickly. And so they can actually become pretty ventilator dependent in a very quick amount of time. And, eventually that diaphragm is going to, it's not just going to atrophy, but the body is going to begin to actually catabolize it or break it down. So we really want to maintain mobility and prevent muscle wasting as much as possible. We've talked about communication already. We've talked about stress reduction and coping techniques. Information. Knowledge is power. Even though the patient is intubated and maybe they cannot talk to you, you can still explain what you're doing to them. So talking to them when they're in the room, when you're in the room, interacting with them on kind of a normal level, explaining procedures that you're about to do, telling them, reorienting them to the day and the time, and just, explaining the treatment plan. If they're not sedated, if they're awake enough to understand it, just kind of talk them through their treatment plan and kind of help, their coping. Monitoring for complications, very important. Family teaching and emotional support of the family. It's very scary for the family members when they come in and see their loved one on the ventilator. So if you can just take some time and explain what everything is, knowledge is power. The more you tell them, the more they understand, and the more you can answer their questions and help them understand, the more calm and comfortable they will become. And so it makes the whole process better for you, for the family, for the patient. It really helps make that critical situation or scary situation better. Other teaching points for long-term ventilator care or long-term trach patients going home on the ventilator. It's a very demanding thing for the family or the caregiver. It's 24 hours a day, 7 days a week monitoring. The family has to know, how to take care of the machine. They have to understand what to do in power outage. They need to understand, what to do if the ventilator doesn't function properly, if the patient is in distress, if they're showing signs of hypoxia. They need to know what those signs are. They need to know how to suction. They need to know how to do oral care. They need to know signs and symptoms of an infection that need to be reported. All of the things that we as nurses monitor for in the hospital and assess for in the hospital, we have to teach the family, so that when that patient gets home, the family can interact with them and be able to provide good care for them. So let's talk about weaning for a minute. Weaning is the process of getting the patient off the ventilator, of withdrawing support or dependence of the ventilator. So, you know, patients may be ventilated for a very brief amount of time, just a day or two, and they might be ventilated for weeks. And it's not necessarily just getting the ET tube out of their mouth. It's, maybe they've had an ET tube and then we had to put in a trach and they've been intubated for a month now, or on the ventilator for about a month now. And we want that to begin that process of reducing their dependence on the ventilator and allowing their body to resume that normal, natural respiratory pattern. So our criteria for weaning the patient is a stable patient, meaning they've got stable vital signs and stable ABGs, normal ABGs, okay? That the patient is showing signs of improvement from whatever was going on with them. If it was infection, that infection is resolving. If it was respiratory failure, the ABGs have turned back normal. Our acidosis has resolved. We've got to have a stable patient, stable vital signs, and normal ABGs or near normal ABGs. Our goal when we are weaning the patient is to have that oxygen level, that arterial oxygen level between 70 and 100, even when they're on room air. That's really where we want them to be because that's where normal people live. So our goal for weaning is to have an arterial oxygen level between 70 and 100. So when we're getting the patient ready, we're getting ready to start this process, we need to explain to the patient what's happening. Obviously, if we're withdrawing some of the support with the goal of withdrawing total support of the ventilator, then the patient has to be awake. They have to be able to initiate their own breaths. They've got to have a strong respiratory effort to be able to breathe without the help of the ventilator. So you've got to explain to them what's going on. You've got to tell them what to expect. The method is physician to physician, really. There are different processes. There are different ways that people will wean from a ventilator. A lot of it depends on the patient's condition, how sick they have been, if they have any underlying health problems or lung disease or heart disease, how long they've been ventilated to start with. It's much easier to wean a patient who's been ventilated for a very brief period of time than it is to wean a patient who has been ventilated for a long time. Everybody who has surgery, anybody who goes under general anesthesia, is put on a ventilator. If that surgery takes 30 minutes or an hour or 2 hours, they're still easier to get off that ventilator than somebody who's been in ICU on the ventilator for a week. The longer the patient is on the ventilator, the more dependent they become on it. So the longer they've been intubated, the longer they've been ventilated, the longer it's going to take to wean them off the ventilator. But it's a gradual reduction in support, changing those ventilator modes and changing our settings to where maybe they were getting 16 breaths a minute and then now they're getting 12, and then we're going to turn it down to 8 and then to 6 and then to 4, and then we'll put them on pressure support only. Reduction in the percentage of oxygen. Maybe initially they were on 100%, then 80%, and then we were able to go to 50%, and then they weaned them down to 30%, and we can leave them on about 30% on pressure support until we can get them extubated. So it's just that gradual reduction in support. If you'll look at page 519, chart 2117, there is that chart talks about assessment parameters that you need to look at as the patient is being weaned from the ventilator. Typically, it's work of breathing, vital signs, oxygenation, signs of perfusion. So make sure you review that chart and be very familiar with it. As we talk about weaning from oxygen, that, there is a continuum. I talked about it earlier, a continuum from room air, no support, all the way to being intubated or having full support from the ventilator. Now, once we get them off the ventilator, then typically once they're extubated, they're going to be placed on either 100% non-rebreather or a venti mask, a higher level of support, a higher level of oxygen. Sometimes they'll be put on a face tent. And then just as we weaned them from the ventilator, we will continue to wean them from oxygen, decreasing the level of oxygen that they are receiving, maybe over a few hours or a few days, depending on the patient's condition and how they tolerate it. But the goal is to get them to the lowest amount of oxygen needed to maintain their O2 sat greater than 93%. Sometimes that's room air. Sometimes they eventually get to room air and they're okay. Sometimes if they have underlying lung disease and they wore oxygen at home, then we are only going to get them back to whatever their baseline was. So, but once we wean them from the ventilator, then we continue to try to wean their oxygen level and get them either back to baseline or get them to room air. There's a lot of nutritional support that is needed during the weaning process because, I talked about before about being intubated and the work of breathing, how it requires increased calories. So there is a very much increased caloric need for patients on the ventilator and then during the weaning process. They burn more calories when they're sick. More calories are burned when they're on the ventilator, largely because of the atrophy that the diaphragm experiences. So as we begin to work the diaphragm again and get it back functioning, there's an increased need for caloric intake. Also, many disease processes for which a patient needs to be intubated, they increase the work of breathing, and so that burns more calories. So we've really got to bump up nutritional support and make sure that the patient is being fed in some way while they're intubated and during the weaning process, so that not only do we support the work of breathing, but we support their healing needs, we prevent muscle atrophy, we prevent skin breakdown. Now, how do you feed an intubated patient? NG tube and tube feeding. Or, if that's not an option, using the gut is always the first choice. But if that's not an option, then they need to be on TPN. We've got to have protein, we've got to have calories to prevent muscle atrophy and skin breakdown. It's very important. So if you have a patient who's intubated and you're looking at day 2 or 3 and they don't have any nutrition going, then it's our responsibility to ask the doctor if we can start some. All right, next let's talk about thoracic surgery. Thoracotomy is our basically the procedure that we're talking about here. It's not really much different than cardiothoracic surgery. We're doing baseline physical assessment, lung functions, labs, chest x-ray, possibly CT scan or MRI. We want to know what their baseline O2 sat is, what's normal for them. Some people, their baseline room air O2 sat is, 100%. Other people, it might be 96. Some people, their baseline room air O2 sat might be 80 or 86. We just need to know what's baseline. We also want to review the health history, especially as it pertains to lung problems. Were they a smoker? Are they a smoker? Do they have COPD or asthma? If they are a smoker, you want to know the pack year history, which is the number of packs per day times the number of years. So I always ask my patients, are you a smoker? If they say yes, then I say, how much do you smoke? How many packs a day, and how many years have you been smoking? Anybody who's been smoking at least a pack a day for at least 10 years is going to have some underlying COPD. They may not really be symptomatic with it, but their body is very used to cigarettes, and when you go for a period of time and you're used to smoking and you don't have it, then that can actually cause an increase in mucus production, and it can cause some negative outcomes for these patients. So I always want to know how much they smoke and for how long, how many years. Preoperatively, we're going to be doing measures to promote airway clearance, which is teaching them coughing techniques, turn cough and deep breathe measures, huff coughing to clear secretions, incentive spirometry, talking to them about mobility early on, teaching them about medications, that they might be on a breathing treatments or bronchodilators or mucolytics. Other teaching points are going to be preoperative, postoperative care, where their incision's going to be, how big is it going to be, pain control measures, and then dealing with their anxiety, answering their questions, doing a thorough teaching. Knowledge is power. So the more you can tell them, the more you can explain, the better their outcome will be. Postoperative management, again, starts with a very thorough physical assessment. You want to compare your postoperative findings to that baseline preoperative assessment. You're looking at level of consciousness, lung sounds, respiratory effort, work of breathing, oxygen saturation, how much oxygen are they on, signs of perfusion, color, cap refill, just are they breathing effectively? Do they have good chest rise and fall? Is their chest symmetric? Whenever we do thoracic surgery, we're actually going into the lung to do the procedure, and so there's always a risk of pneumo. There's always a chance of infection. And of course, there's always the chance of atelectasis. So really comparing your postoperative assessment to the preoperative, what are the lung sounds now and what were they before he went to surgery? What are those baseline, or what are those oxygen saturations now, and what were they preoperatively? Baseline room air sats, what were they? So a lot of comparing there. Pain control measures, teaching the patient how to splint their incision, liberal use of pain meds. Nobody's going to get addicted to narcotics in the 3, 4, 5 days it takes to recover from a thoracotomy. But they will get atelectasis, which can lead to pneumonia if they don't breathe deep because they're hurting. So pain control, encouraging the patient to utilize pain medicine, ask for it, teaching him how to splint the incision, turn, cough, and deep breathe, getting them out of bed, if possible. CPT, suctioning. If they're mechanically ventilated, then implementing all of those measures to prevent pneumonia and enhance their oxygenation that we've already talked about. So one thing that you might see in a patient who's had thoracic surgery is a chest tube. So let's talk about chest drainage for a minute. Again, the normal chest environment is negative pressure. So any increase in fluid or a buildup of air can lead to a loss of that negative pressure situation, and it can actually put pressure on the lung and cause it to collapse. If that's the case, then we need to insert, we do not insert chest tubes. The doctor will insert a chest tube, but we need to assist with insertion of a chest tube to reinflate that lung, to re-expand that lung, and then remove all of the excess air or fluid or whatever's in there that caused the lung to collapse in the first place. So chest tubes are used to treat spontaneous pneumothorax or a traumatic pneumothorax from trauma, from a car accident or blunt trauma, something like that. A spontaneous pneumothorax is just exactly what it says. It is a patient who develops a pneumothorax for no apparent reason. Actually, you can see spontaneous pneumos fairly frequently in very young, healthy, thin males. A lot of times we will see them in teenagers, in early 20s. Sometimes it's related to playing sports, basketball, football, but there's not necessarily any trauma or injury related to it. They're thin, and for whatever reason, that lung just collapses. So when we talk about chest drainage systems, if you will look at page 524, table 21.3, there is a description of the different types of systems. And I'm going to try to explain a little bit about these systems, these different ones, and then we will look at actual pictures in class, which will help tremendously. So if you don't understand it right now, jot down whatever questions or areas that you don't get, and we will try to make sure we go over it in class more specifically. So there are 3 basic types of drainage systems. Okay? There's a traditional water seal, the dry suction water seal, and then just dry suction. Those are the 3 different types of chest drainage systems. Now, all 3 of these types have some things in common. Okay? They all have a suction source, they all have a collection chamber, and they all have some type of mechanism that prevents air from going back into the chest. And that mechanism is called a seal chamber. Okay? So all 3 types have suction source. There's got to be some way to hook them up to suction. All of them have a collection chamber to collect the air that is escaping or fluid that is being drained. And then they all have a seal chamber or some way to prevent air from backflowing into the chest. Okay? Now some of these seal chambers are a wet seal where we use fluid, which is the traditional water seal, or some of them have a dry seal chamber, which is the dry suction water seal. Okay? Now I know that sounds crazy and it's probably very confusing, but again, we're going to go over it in class. Okay, so a traditional water seal or a traditional system is one that has all of those components, the suction, the collection, and the seal chamber, and they're used to reinflate the lung and drain any kind of fluid or blood or anything that might be draining from the chest. Okay? So in our traditional water seal system, the seal part is sterile water. There is a chamber that is filled with sterile water, and that is what prevents air from being sucked back into the chest on inspiration. Now, in that water seal chamber, you should never, under normal circumstances, there won't be any bubbling or rolling. There won't be any air bubbling going on in that water seal chamber. If you see a bubbling in the water seal chamber, that means that there is air escaping out of the lung, and it's called an air leak. Now, if the patient has a pneumothorax and we put in a chest tube and we've just hooked up this chest drainage system, then it's possible that we are going to see that air leak. We should see that air leak in the water seal chamber at that point, because the lung is being reinflated, and it's all of the air that has gotten into the chest is being pulled out, and the lung will reinflate and seal itself off. So initially, in a patient with a pneumothorax, initially you might see that air leak or that bubbling in the water seal chamber, and that would be okay. But once that lung is reinflated, that air leak should go away. If you have a patient with a chest tube and you assess them, you should always assess initially your baseline, assess for an air leak. And make note, if you see bubbling in the water seal chamber, that's important to know. If you don't see bubbling in that chamber, that's important to know. Later on, you go back. If it's different, then that's a significant change, and the doctor needs to be notified. Okay? Occasionally, with water seal systems, you will see the water level kind of go up and down as the patient breathes. The water level, there'll be a slight increase in water level when the patient inhales or on inspiration, and then it'll go back down to normal on expiration. That's called tidling, just that up and down with respiratory movement, with inhalation and exhalation, and that's okay, that's normal. But a constant bubbling in that water seal chamber is indicative of an air leak. And, you know, it depends on why your patient has that chest tube, whether or not you expect an air leak, but eventually that air leak should go away. Patients who have had thoracotomy, and we're just using that chest tube to drain fluid or blood, and it's not for pneumothorax. You know, if you assess the patient, they don't have an air leak, and then you go in later and you notice that they do, that's a big problem. That means that they probably have a pneumo, and that needs to be looked at. So, now with our dry suction system, or dry suction water seal system, what that means is that there is no, well, let me back up. With that traditional water seal system, there is the water seal chamber that's sterile water that I just talked about, and there is another reservoir that we fill up with water that the suction source is connected to. And the suction source causes a constant bubbling or a constant rolling in the suction chamber, and that's how we know that we have a sufficient amount of suction on that drainage system. The appropriate amount of suction for a chest tube drainage system is -20 centimeters of water. Okay, if it's a water seal, it's -20 centimeters of water suction. If it's a dry suction system, then there will be some sort of suction dial or setting that you set to 20 centimeters of suction. And then when you hook suction to it, it automatically pulls at 20 centimeters of suction. But that's the appropriate amount of suction that's not harmful to the thoracic cavity. So in our traditional water seal systems, or wet systems, you've got the water seal chamber where we're looking for air leaks, and then we have the suction chamber that actually has sterile water in it also that bubbles when it's connected to suction. In our dry suction systems, we have the water seal chamber where we look for air leaks, but instead of having the water chamber or suction chamber with water in it, it just has a knob or a dial that we set to 20 centimeters of suction. So, and that's all. It's still connected to suction, but there's no water bubbling to create the suction. And with dry systems, dry suction systems, those are actually just one-way valves. Those are what's called a pneumodart. It's a very small chest tube, and they're usually only used for pneumothorax to reinflate the lung. They do have a small collection chamber on them, but they have like their own self-suction, and they're very small. So that's a little bit different than the traditional and the dry suction. So again, we're going to look at these in class. We're going to look at pictures. So read through it in the book. If you don't understand it, just make notes, and you know we'll go over it more in depth. So don't freak out, okay? It's going to be all right. We're going to get there. So management of a chest tube, if you'll look at page 525, some management things that you need to make sure and assess for. Make sure that there are no kinks in that tube, that the chest tube, first and foremost, that the chest tube is patent, it's draining, and it is secure to the chest wall. Now, the actual chest tube itself is going to be a more rigid type of plastic, and when that actual chest tube ends, or where the chest tube ends, it connects to the drain tube that goes into the drainage system. And there's a little connector that connects the two tubes together. That connection needs to be very securely taped so that it does not come apart. Remember, the chest is a negative pressure environment. If that chest tube becomes disconnected or dislodged, then that lung will immediately collapse. So we've got to make sure that the tubing is very securely taped. You want to make sure that your chest drainage tubing is not only not kinked, but that it's not clamped off. We never, ever, ever clamp a chest tube, except when it's being removed. Okay? That is the only time it's acceptable to clamp a chest tube. If you are transferring the patient, if you are ambulating the patient, if you are, moving them from taking them to x-ray or whatever the case may be, you never clamp a chest tube. It should always be open to drain. Should be connected to suction at all times, unless your doctor orders it to be placed to gravity, and then you can remove the suction. But otherwise, it should always be to suction. So you're responsible for checking the integrity of the tube, making sure it's not kinked, make sure that it is draining, that the connections are secure. You're responsible for keeping up with how much the patient has put out of that chest tube during your shift. So what kind of drainage is coming out of it, and what does it look like, the color, the consistency, are there any clots in it, stuff like that. Is there an air leak in that drainage system? You're responsible for that. On top of the patient's work of breathing, respiratory rate, depth, pattern, effort, that kind of thing. Prevention of complications. Page 527, if you look at the chart 2121, it goes over complications, which basically is pneumothorax, an air leak, becoming dislodged, things I've already kind of talked about. Okay, so make sure you review potential complications and are familiar with them. All right, some of our postoperative nursing interventions or nursing management that we really just want to make sure and keep track of in a patient who's had thoracic surgery. Of course, monitoring our respiratory and cardiovascular status, rate, depth, work of breathing, oxygenation levels, blood pressure, heart rate, signs of cardiac output, adequate cardiac output. We want to promote gas exchange, enhancing breathing techniques, airway clearance, turn, cough, deep breathe, CPT, positioning, suctioning, incentive spirometry, mucolytics, medications as ordered, pain relief. We've already talked about judicious use of pain meds, keeping the patient comfortable, splinting, promote mobility, get them out of bed, get them up walking as soon as possible, at least get them out of bed to a chair, and then maintaining our fluid status. We want to make sure that they have proper nutrition, that they're getting the proper caloric intake, and staying hydrated, but yet not overloading them. Want to keep up with renal function and urine output, and make sure that we are maintaining that fine balance between staying hydrated and not becoming overloaded. So that concludes the lecture on respiratory therapy modalities. We will be discussing the respiratory system a little more in depth in our next lectures, and I will be referring back to a lot of this information in terms of ventilation and indications for ventilation and things like that as we move